All right.
Got it.
Hi, good morning. Good evening. This is our second in our series of uh, vet Zooms, and who we have tonight is Kathryn Golden. She's going to be talking about colic and other equine emergencies. Dr. Golden is with the equine practice out of Northern Lakes Equine Practice out of Lake Zurich in Northern Illinois. She's a native of Northern Illinois and attended the University of Illinois College of Veterinary Medicine. Then completed a rigorous equine internship at Carolina Equine Hospital in Greensboro, North Carolina. Her professional interests include ophthalmology, dentistry, preventive medicine, and sports medicine. She is an active member of the American Association of Equine Practitioners, as well as a board member of the Illinois Equine Practitioners Association. Let's all welcome Dr. Golden, and I'm going to turn it over to you now.
All
Dr.
right.
Golden.
Thank you so much. It's a little bit interesting to do Zoom meetings now. It's so different than seeing everybody in person. So as someone who feeds off the energy of other in the room, I will do my best to still make this a captivating lecture about equine emergencies. I'm really excited to be doing this with you guys. I believe there is a chat function. So if you have questions as we go along, Molly is, and my dog. All right, we're gonna pause for half a second. I'm opening the door and they will be gone. I'm so sorry.
There is a chat function that you'll be able to use to ask questions. So once you start we start the process, please use the chat function, and we'll make a decision whether it's something we're going to interrupt Dr. Golden on, or whether we'll hold it till the end of the presentation.
Perfect, wonderful. I'm so sorry about that. Dogs, I'm a veterinarian with animals. So anyways, so I'm really excited to be talking to you guys tonight about equine emergencies. We are going to focus the majority of this lecture on colic, because that is certainly something that we see so very often, and something that I think there's a lot of misinformation out there about, and a lot of good information. So we're kind of going to run through the gauntlet. I like to make all of my talks I like to take my group back to vet school with me, and we're going to go through some anatomy and physiology and understand the basics of the concepts before we talk about the disease process themselves. Later on in the lecture, there are some wound photos, because we're going to talk about wounds as an emergency as well. I do have a little warning prior to those, because there's some graphic images in them, but I just want to make sure that everybody's aware beforehand that we are going to go through some wounds and things like that. So if you're squeamish, I'll give another warning before we get to them. So without further ado, we shall continue on and hope that this works. Okay, so just a little bit about Northern Lakes Equine Practice, because of course we have to give a personal plug. Myself and Dr. Laurel Meininger are partners, and we have a wonderful associate, Dr. Kelly Mannion. We service the Northern Illinois and Southern Wisconsin area. We do lots of preventative medicine, dentistry, sports medicine, ophtho, breeding, chiropractics, acupuncture, and of course, emergency coverage, which is what we're here to talk about tonight. So just some fun videos. All right, so let's talk a little bit about colic, and I need to just move my screen here a little bit so I can see. All right, so colic, as all horse owners, so it is a word that as horse owners we fear. I myself am of course a horse owner, and it's actually part of why I became a veterinarian. I have loved horses my whole life, as many of us do. And when I was in college, I had to take a equine health and first aid class, and we learned about colic, and in particular strangulating lipomas, and how Arabian horses were one of the breeds that were predisposed to that. And I thought, oh my gosh, I have an Arabian. I need to become a veterinarian so that I can save my horse if he should suffer from this. And so one of the things that that I took away from that class was colic, and it being so very important in recognizing early and working on before there is a larger problem. So Colic is an umbrella term. It basically just means there is pain in the abdomen. And so horses can only show us that they're painful in so many ways.
Excuse me just a second. Jan,
Yep.
could you please take your video off? Jan Nestron. Thank you.
All right, so we'll continue. So colic is a very general term. It is an umbrella term. Horses can only show us they're painful in so many ways. They often will not eat, they will paw, they will roll. Sometimes they'll kind of stretch out or park out and make frequent attempts to urinate. Sometimes they'll just be standing quietly away from the herd. But what I always tell owners is that know what is normal for your horse. And in any situation, whether it's colic or fever or any of the other things, knowing what's normal for your individual horse will help you understand what is abnormal. And so these are the types of things we want to be able to recognize, but anything that's abnormal is a reason to maybe phone your vet and give them a heads up that something is wrong. See, all right, no, there's our umbrella. Okay. So in order to understand colic better, one of the main things that I see as a veterinarian is there's a lot of misinformation about people will say, oh, I have a friend that their horse colicked and had colic surgery and then it didn't go well, so I would never do colic surgery on my horse. And I think what's really important to take away from this particular portion of the lecture is that not every colic is the same, and not every colic surgery is the same. And so I want to help you guys understand what the difference between different types of colic and different types of colic surgery are. Because the more educated horse owners are about the different types of colic, the better that our patients will get the appropriate treatment at the appropriate time. So the first thing here, just like in vet school, before you can understand the pathology, you have to understand the anatomy. Can you see my cursor if I move my cursor? I know Molly, you might have to chime in and tell me. I forgot to ask you before.
Yes, we can see the cursor.
Okay, perfect. So the equine digestive tract is made up of the esophagus, which is the food pipe, which attaches the back of the mouth or throat all the way down to the stomach. Then we have the stomach, which is the first part of the digestive tract within the abdomen. We have our small intestine, and the small intestine is made up of 3 different parts: the duodenum, the jejunum, and the ileum. We then have the large intestine, which wraps around and is kind of layered in the abdomen and folds and turns. And I'm going to show a video in the coming screens, which just shows that just these tight hairpin turns. And in many areas of the large intestine, we go from a large diameter to a small diameter, back to a large diameter. And the changing of diameters and the hairpin turns that happen are the reason that we see colic so frequently, unfortunately, in horses, because their digestive tract has all these little areas where hiccups could happen. It's kind of like driving a really windy road at night. You have to be careful how you navigate. And sometimes if we're not careful how our food is navigating through the digestive tract, we will run into issue. And so in our large intestine, we have the cecum, which is located on the right side of the horse. So if you've ever had your veterinarian out to do a examination or a colic exam and they listened for gut sounds, we like to listen on the left side in the upper and lower quadrants and on the right side in the upper and lower quadrants, because that tells us about different parts of the digestive tract. And it will help us localize where the problem is on our physical examination. So on the right side of the horse, we have our cecum, which is our area of major fermentation and digestion for the horse. And the cecum is this huge vat, but the exit of the cecum is only a very small hole. And so we can see a lot of issues with that. The cecum empties into the large colon and then eventually becomes the small colon. So we're gonna watch, this video is available on YouTube. It's one of my favorite videos to show owners when we are at an emergency or at a colic exam. I like to play this. And I'm not sure if you'll be able to hear the audio, so I'll kind of narrate through it as we go. So this is the stomach, which is positioned on the left side of the horse in the front. From the stomach, we have our duodenum, which is part of the small intestine. Then we have it branching into our jejunum, which is the major portion of the small intestine. So we're going to see that kind of show up here. It's about 70 feet long in the horse. It's not all going to be shown in here. So this is the ileum. So that's the last part of the small intestine. You can see how small that little hole was from the ileum into the cecum here, how big that is. So it's going to leave our cecum by a small little area. Look at all of those turns. Look how sharp that turn is right there. That's all large colon, and now we're going to have small colon right here. And then out the rectum. So I just love that video because I think it does a really good job highlighting just how many twists and turns the equine intestinal tract makes. And knowing where the problem is and where the colic is, or where the pain is coming from in a colic situation greatly impacts how the colic will proceed forward and how we might, as veterinarians, the recommendations we're going to make. So we're going to talk a little bit in generalities because obviously every patient is different. And I think that's another takeaway from this lecture that I want you to have is that no two horses are the same, no two patients are the same, and every patient needs to be looked at like an individual. And so we're going to speak a lot in generalities tonight, but having a relationship with a veterinarian that you know and trust is massively important because they know your horse and can help you specify what's happening to your particular horse in any situation. So we're going to talk a little bit right now about the stomach and the small intestine and how it relates to colic. So there are various types of colic that we can see from the stomach and small intestine. So we all know those horses that are a little bit ulcery or maybe majorly ulcery that show us some pain after they eat their grain, or maybe they eat their grain and then they start to feel a little bit funny as they're eating it. So that is going to be pain that is coming from the stomach itself. Those horses are usually managed medically, and those typically don't turn into major colics or colics that require surgery, but can be a cause of chronic low-grade colic around feeding time. The only way to diagnose ulcers in a horse is with an endoscopy procedure where we pass a camera up the nose and down the esophagus into the stomach, and we can get really wonderful images of the stomach itself to look for ulcers, not only on the squamous portion of the stomach, but on the glandular portion of the stomach. And so we will frequently see gastric ulceration as a cause of mild, intermittent, low-grade colic in horses. Gastric impaction, fortunately, is fairly rare in the horse as compared to dogs and other species. We can see hairballs, which are called trichobezoars. We can see foreign material or other things like that. But gastric impaction is a fairly uncommon presentation of colic in the horse. Strangulating lipomas are, if you remember from my story from the beginning, kind of the reason I was inspired to go to veterinary school when I learned that Arabian breeds were very prone to developing strangulating lipomas. And in the images here, these are actually images from colic surgery from my Arabian horse who did develop a strangulating lipoma a few years ago. And what you can see is that a strangulating lipoma is a fatty tumor, these little balls of fat that grow on these stalks of fat, like a tether ball. And they grow from the mesentery that connects all of that jejunum, that small intestine. And they end up wrapping around portions of the small intestine. And just like if you were to wrap a rubber band around your finger very, very tight and it cuts off the circulation, that's what happens in these situations too. And so surgical intervention is the only way to heal a strangulating lipoma. And the earlier our intervention, the better, because while that stalk is wrapped around here, we are having severe blood loss and dying of our intestines. And so strangulating lipomas are a surgical correction to colic only. We can also see epiploic foramen entrapments, this is the mesentery of the horse, that's the portion that holds all that jejunum together. And there is a natural area towards the base of it that is a small hole or a rent. And the epiploic foramen is basically where the normal intestine goes through the normal hole, because it's all kind of free floating in there. And if the harmony of how they're contracting and moving along, or if the harmony of the peristalsis, which is the contractions that move food from one end to the other, are disrupted, sometimes the intestines will accidentally find themselves on the other side of this hole that they were never meant to be on the other side of, and we will see strangulation or loss of blood supply to the area that's gone through the hole. And that, again, is a surgical type correction. Volvulus is where the intestine, just small intestine, remember, we're just talking small intestine here, this thin little tubes where it twists on top of itself. And again, that is causing a loss of blood supply and is primarily a surgical correction. Enteritis is where we have severe inflammation through the small intestine. And enteritis, unfortunately, there's very little way to differentiate it between some of these other strangulating lipomas or volvulus or epiploic foramen entrapments. When the horse is standing in front of us, it's very difficult to differentiate enteritis from these other types of colic. Enteritis actually is primarily managed medically, but often the diagnosis is made at surgery when we open them up and realize that they don't have some of these other things going on. So while enteritis is something that's managed medically, it's often a diagnosis at surgery. So things you should take away from this slide are that stomach and small intestinal colics, they tend to have increasing levels of discomfort where the patient is maybe not so bad at first, maybe just a little bit off their feed, but then pretty darn rapidly is really down and rolling, is really hard to keep on their feet. They are very, very uncomfortable. And in these sorts of situations, time truly is of the essence, because as you can see here, a lot of our corrections for small intestinal issues are actually surgical. And the quicker we get into surgery, the quicker we introduce that intervention, the better the prognosis. And that happens for a couple of reasons. The first is that as our intestine is dying, there's all these blood vessels that are around here. And so all of the toxins that are coming out of the dying intestine are now being poured into our bloodstream. And we can get secondary complications like laminitis and things like that, which are also very difficult and very frustrating to deal with sometimes. We also want to avoid a resection and anastomosis as much as possible. A resection and anastomosis is where we actually have to cut out a part of the intestine. And so fortunately, in my horse's case, we were able to avoid that. And in most cases, when we are able to avoid a resection and anastomosis, the complications from surgery are typically less than when we have to cut a part of intestine completely out and sew two new pieces together. So this is one of our takeaways, is that a resection and anastomosis is a little bit more complicated to overcome versus just a plain surgery where we're able to go in and remove the offending agents without actually having to open the intestines themselves. All right, looks like we have someone in the waiting room. Okay, here we go. All right, let's go to our next page here. Oh, come on. All right, now we're going to talk about the large intestine as it relates to colic. So the large intestine is after our small intestine, after we go and we empty into that cecum, which is the big vat that does the majority of digestion on the right side of the horse. Now, as it exits the cecum, we dump into the large colon. And the large colon, we see various sorts of issues. So as we were going through that video and we saw all the hairpin turns that were happening here, this, where I'm using my cursor right now, is the most common site of gastric or of large intestinal impaction. This is called the pelvic flexure. It's on the left side of the horse. We go from a very narrow diameter to a very large diameter to a very narrow diameter. And as it's doing that, there is this literally a hairpin turn here. And so things will frequently get stopped here if the patient doesn't have appropriate hydration. And so this is a very common type of colic to see when we're having the weather fluctuating a lot and patients sometimes aren't drinking as much as they normally would. We will see impactions happen in the pelvic flexure area. Up here in where this image is showing, this is the diaphragmatic flexure, and we will also see impactions start to happen up here. Unfortunately, when we're performing a rectal exam, we can feel this area. This area is well beyond where we can feel, and so we don't always know that that exists or that that is there. Okay, so impaction is a type of large intestinal colic. So impaction is fairly self-explanatory, but it basically means feed stuff that are stuck and not moving. They are impacted and they are not moving. So right here, pelvic flexure impaction, and then over here, we will also see cecal impactions. Cecal impactions have been reported with patients that are having orthopedic pain, as well as patients with ocular pain. We sometimes see an increased predisposition for developing an impaction of our cecum after that. If the impaction is dealt with early enough, or we're able to intervene before the patient just starts cramming in more food, then we're usually able to relieve them medically with hydration and limiting of the feed stuff that we're adding. Sometimes though, if they just keep eating or they start to feel better and they kind of start eating, but they're still not in that good place, we will see these impactions get incredibly large. And in those situations, we are not always able to get them to relieve medically with IV fluids or oral fluids. Sometimes these patients do need to have surgical intervention to have the colon emptied out. But for the most part, an impaction is a medically managed colic. Displacement also can be medical or surgical. A displacement is simply where part of the colon, when it's supposed to be here, has flipped over and put itself in another location. Those are sometimes able to be managed medically if we can restore harmony to the peristalsis and we can get things communicating well. Sometimes if they haven't been sitting there for too long, they'll be able to flip back into their natural position. But if they've been there for too long, or if there's gas that started building up in that portion that's displaced, then unfortunately we do sometimes have to go in, open them up surgically and just flip it back into place. And it's a fairly simple procedure to be able to just move it back to where it needs to go. We don't need to do like we were speaking about with in the small intestine where we do a resection and anastomosis. If we can avoid cutting out portions of the intestine or opening up the intestine, the procedure itself is actually relatively simple and the fix. And those horses tend to do very well after surgery if we're able to get in there and intervene quickly. A torsion is where we have the large intestine twist on itself. And those will sometimes mimic a small intestinal colic in the sense that those patients are very painful very quickly because we have a massive loss of blood supply to a viscera very quickly, and those horses get very, very uncomfortable very quickly. Enteroliths also can be managed medically or surgically, and we have some pictures of those here. So enteroliths are little stones or little rocks that can form through the digestive tract. They can form for various reasons. Sometimes it's the substrate that we're eating. Sometimes it's the surface that we are eating upon. We see these a lot in California and sandy areas where there's a lot of sand in the soil because they'll be consuming sand at the same time. We're going to talk about sand colic in a second, but the enteroliths form into these little stones that can get lodged. And that's actually what's shown in this picture is an enterolith here, an enterolith here. And here my tech and I are also holding on to an enterolith that was removed from a patient. But enteroliths sometimes are small enough, like these guys, to just pass in the manure of the horse. And other times they're very large and cannot pass anymore. And thus we need to go in surgically and remove them. Sand colic is often just a medical type colic where we will see some, mild irritation. We can do a sand test on the feces or the manure that's coming out of the horse themselves to look and see if that's a chronic problem. Fortunately, in our area of Illinois, we don't tend to see sand colic nearly as much as other areas of the country, but it certainly is something that we have to have on our list. A gas colic is, I'm sure everybody has heard of that very common term. We hear, oh, he just, he needed to pass a little gas and now he's a lot better. Gas colic is anywhere through all of these portions of intestine. If the harmony of how they are working together, that peristalsis. It should be a happy union moving through. But sometimes for whatever reason, whether it's stress or a new feed that's introduced or any of those things, if that isn't working in harmony, sometimes gas will build up in one particular area. And as gas builds up, we get a stretching of the intestine, and that's a painful thing for the horse. And so they'll start showing us signs of colic. Fortunately, typically we are able to relieve that pain rather quickly with some of our interventions and restore them back to a normal harmony. But if we can't, then we do sometimes have to go in surgically and express that gas. Gas colic is much more commonly managed medically, but in very rare cases can be a surgical issue. Spasmodic colic is essentially when we were talking about that peristalsis, the things that move along quickly or move along in harmony. If one's going fast here and the other one's going slow and they're just not happy and not working in union, we will see a spasmodic colic. And sometimes we need a reset button. And we're going to talk about some of our treatments for colic and how those are a reset button and how they can help the horse get over some of these more medically managed colic. And so we have just listed through between these last two slides, a handful, 15, 16 different types of colic specifically. And this is just a general overview. So remember, my main takeaway that I want you to have from this is that not all colics are the same. And while we share experiences as horse owners amongst ourselves, it isn't always appropriate to say. What always makes me sad is when I hear somebody say, well, my friend's horse colic and they did colic surgery, and because of that, I would never do colic surgery for my horse because it was horrible. Well, maybe that friend's horse had really bad strangulating lipoma that was there for a long time, and the horse had lots of dead intestine, and they still proceeded with surgery and tried to get them off the table or wake them up after surgery, and things didn't go well. That's a very, very different type of colic surgery than a simple displacement where we literally go in, open them up, and flip them back into place. And I should say here that I'm actually not a surgeon. I am just a general equine practitioner. So I send surgeries to other wonderful skilled surgeons in our area. But it still is a relatively simple procedure as compared to a resection and anastomosis, which requires a lot more, it has a lot more complications associated with it. And so it's not that a resection and anastomosis should never be done, but they should not be compared to a simple displacement type colic. Those two things are not the same. Even though they're both termed colic, they're not the same thing. And that's really what I want people to understand, is that there are differences between colic. Colic is not one thing, it's many things. And so with large intestinal colics, we typically see that the pain signs can vary greatly. They're oftentimes, as compared to small intestinal colics, less painful. And many of these can be managed medically or surgery. It just depends a little bit. All right. I think we have talked about that a lot. So what does this mean for you as horse owners? What are some of the treatments and diagnostics? How do we determine whether we have a small intestinal problem or a large intestinal problem? And what should you do as horse owners to help your horse as well as your veterinarian in a colic situation? So I listed over here the 1, 2, 3s. So the first thing that you can do is remove feed. Many of these horses are not eating anyways because they don't feel great. But sometimes as they start to feel a little bit better, they want to start eating. But if they have an impaction that hasn't been fully resolved and we start adding food on top of it, that impaction can recur. So the first thing you should do is remove all of the food from your horse's surrounding area. Start doing some hand walking if it's safe to do so. Some of these horses are so extremely painful that hand walking isn't possible. And if that's okay, the first and utmost priority is always your safety. Don't get hurt trying to get these guys up or get trapped in a stall with them. But if it's safe to do so, get them up and start hand walking them if you have an area to do so. And always just call your veterinarian, even if it's just a mild thing. We would so much rather hear from you and have you tell us what's going on so we can interject and tell you what we know about what you're describing versus finding out hours and hours later that it's been going on. We'd much rather be on your team, even if we're not there at the stall side, getting these things started. So the first 3 things you should do are remove feed, start some hand walking, and phone your veterinarian to let them know there's something going on. If we ultimately come as veterinarians, what we're going to do is we're going to perform a physical exam. So we're going to listen to heart rate. We use heart rate as an indicator of pain. And so, and again, none of these are hard and fast rules, but this is, kind of the generalities. We're going to listen to a heart rate. And for the most part, a heart rate that is normal is a really good sign. So what's normal in the horse? The horse's general heart rate in a non-painful horse that's not having physical exercise should be between 28 and 40 beats per minute. It's pretty darn slow. So one of the things that sometimes will happen when clients call me after they've tried to take a heart rate is they'll tell me it's 80. But really what's actually happening is they're counting the heartbeat twice because the heartbeat is so slow. It goes bum, 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 bum. And so people will hear the bump, bum, and they'll count it as 2 heart rates. And so next time your vet is out, if they're listening to the heart on your horse, just ask if you can take a listen. I love letting people listen to their horse's heart because they're like, it's so slow. And it really, really is. So we're going to listen to the heart rate. We're going to use that as one of our data points as an indicator of pain. We're going to look at their respirations, how quickly they're breathing. We're going to listen to their gut sounds. So we are going to listen in 4 or 5 different quadrants as we are trying to assess different specific areas of the gastrointestinal tract. And for the most part, we want to hear sounds. Even too many sounds or a hypermodal colon is better than no sounds. No sounds is not a good thing. We want to hear sounds. Your veterinarian, when you call them, may tell you to give some non-steroidal anti-inflammatories or typically Banamine, or they may administer them when they are there. But this is my little soapbox where I like to talk about giving Banamine to horses. I always recommend, unless you are comfortable giving it into the vein, that you should always give it orally. Even the injectable Banamine can be given orally safely versus giving it intramuscularly. And I have a little picture down here which looks quite horrific, and it is. This patient is suffering from Clostridial myositis as a result of an intramuscular injection of Banamine. And I guess I should pause here and say, Banamine is a brand name. The drug name is flunixin meglumine, but we are all familiar with Banamine. And so any intramuscular injection with flunixin meglumine, also known as Banamine, has the potential to cause Clostridial myositis because it causes some localized muscle necrosis. So it is always my recommendation, if you're not comfortable giving it intravenously, and you should not do that if it's not something you've done a lot, just give it orally. It takes a little bit longer to work, but so much better than just needing a little bit longer than causing a more, significant, massive problem like we see down here. If your veterinarian is there stall side, they're likely going to administer some sedation or xylazine. I like to call this my little reset button. It kind of breaks the pain cycle. It's going to facilitate a safe rectal examination and nasogastric intubation, which is where we pass this tube up the horse's nose, down their esophagus, into the stomach. As many of you probably know, horses are not really able to vomit or to burp. And so sometimes we'll have things that are backing up into the stomach as a result of stomach or small intestinal colic signs that we need to relieve the pressure on, either through a nasogastric tube. So this procedure, this nasogastric intubation, is not only diagnostic to let us know if things need to come off the stomach, but is also a treatment where we can administer either electrolyte fluids, sometimes mineral oil, and we can certainly have a discussion about the difference between mineral oil and electrolyte in a little bit, but we typically recommend getting some good hydration in there and through the use of electrolyte fluid. We're also going to take a feel rectally where we're going to put our arm in through the rectum if it's safe to do so on the size patient. And while I cannot reach all the way to that diaphragmatic flexure in the very front, I can feel a lot of the colon, and I should never be able to feel small intestine. And so sometimes if I do a rectal exam and I can feel small intestine, that tells me there's a major problem going on more forward that's allowing that intestine to come and be pushed into a place where it shouldn't be. So all of these things are data points: the heart rate, how they respond to pain medication, rectal exam, nasogastric, all of these are just data points. And this is really where, having a relationship with your veterinarian and having them know your horse and where you guys can kind of sort through all of these little things together is so helpful in picking the right course of action for your particular patient. Typically, at a standard colic, we're going to do a physical exam. We're going to administer Banamine if it hasn't been administered. We're going to do some sedation like xylazine. We may or may not give Buscopan, which is a medication that can stop some spasming. And we are going to take a feel rectally. We're going to pass the tube and we're going to administer some fluids. Beyond that, if our patients, and 90% or the majority of colics, doing that alone is going to fix them. They're going to come out of sedation and they're going to feel a lot better. Those are our mild medical colics. All of the other things that we talked about are our more significant, moderate to severe colics that are going to require next step intervention. And I think that grading these on a mild, moderate to severe standpoint is really helpful to do a gut check with ourselves as to where each patient is at, not only for myself as a veterinarian, but for the owners themselves. The majority of colics that are simple are going to respond to these treatments alone. If they come out of sedation and they're still looking painful, I automatically bump them up to that moderate category. And we start doing some additional diagnostics. And those additional diagnostics are things like ultrasound or abdominocentesis potentially, where we start trying to get some more information about what's going on inside the horse's abdominal cavity. All right, so take-home messages. Not all colics are the same. I think I have probably harped on that enough that I hope you guys now understand at least a little bit more about the differences in types of colic. Mild colics are going to respond to early intervention quickly. Sometimes they respond to just some anti-inflammatories on the farm. Sometimes they respond to just hand walking initiated by the owners. Moderate colics are those that come out of sedation or have some non-steroidal administration, but continue to exhibit pain signs. And severe colics are those that, despite all of our pain medications and hand walking, are still really uncomfortable. And any patient that is in that moderate to severe, especially the severe category, if they have the option for referral, those are the ones that need to go to the referral clinic for potentially surgery, but certainly more intensive management than we're able to provide on the farm. So planning ahead is vital. Have a relationship with a veterinarian who you know is going to answer the phone when you call, to just let them know that your horse is having an issue. So know them, establish trust and a relationship with a veterinarian prior to finding yourself in an emergency situation. And that is so massively important. And I can't share that enough with you, because we want to be on your care team. And it is so hard to build trust with somebody in an emergency situation. We'd so much rather have those bonds started beforehand and know your individual patient prior to there being a colic emergency or another emergency, which we're certainly going to talk about here in a second. Have emergency medications on hand, something like Banamine, if that's something that your veterinarian feels safe dispensing to you, and they feel knowledgeable about your ability to use it. That's a great thing to have on hand. A lot of people like to have some kind of emergency medications, but those always have to be given at the direction of a veterinarian and our prescription. If your horse has the option, if you are the type of horse owner and your horse is a good candidate for surgical intervention, have a plan now. Not everybody owns a trailer, but maybe have some phone numbers of some people who you would call, because horses never like to colic when it's convenient at 12 o'clock in the afternoon. They like to colic at 10 or 11 o'clock at night or midnight. And sometimes trying to find a trailer to get the patient to the hospital can add minutes to hours of time that maybe that patient doesn't have. And so have a plan now for trailering, or at least start thinking about it. And also start thinking about whether you would pursue colic surgery for your patient, because not every horse makes a good surgical candidate. And those are discussions to have not only with yourself and your family, but also with your veterinarian, because sometimes people find themselves in these emergency situations and now they're trying to make a very difficult decision while they're filled with a lot of emotions. Really having a good gut check with yourself now and your family, and deciding whether surgery, should your horse in the unfortunate event ever need it, think about those things now so that you have a thought in your head prior to finding yourself in that situation. And then certainly consider colic insurance, or just insurance in general, if that kind of plays into your patient's wellness or health plan. There's a lot of different things out there. And certainly you can ask your veterinarian about them. Insurance is not necessarily applicable to all horses, but it certainly can be very helpful when we find we are in a colic type situation. I will continue moving on unless I am told to do otherwise. And the rest of the topics that we're going to talk about tonight, we're not going to talk about nearly in the depth that we just did with colic, but we are going to blast through some of these other types of emergencies that I'm commonly called about so that we can just at least cover them and make sure that you have heard the terms and it's something that's in your repertoire. And then certainly at the end, if there's questions or as we go along, if you want to stop me, feel free to. We are going to move on to esophageal obstruction, also known as choke. So the main really important thing to take away here is as humans, when we are choking, that means that we have food or some sort of material that is blocking our airway, our windpipe. And that is a major emergency because we are deprived of oxygen in that period of time. And obviously, as we all know, we cannot survive without oxygen for very long. When we talk about choke in the horse, we are not talking about an obstruction or blockage of our airway. We are talking about an obstruction of our esophagus. And the esophagus is the first portion of the digestive tract. If you remember back to our initial slides, it is what connects the back of the mouth to the stomach. And sometimes patients will eat their food so quickly that they will get food that gets stuck in the esophagus and causes an impaction or a blockage of the esophagus. The great news about this is that they can still breathe. And so while this is something we want to correct quickly, it is not something that is going to kill them within 2 minutes. It can look incredibly scary to owners because oftentimes what will happen is the horse will come in from turnout or get put in the stall as soon as dinner's in there. They are excited to go to their grain. They're ready to go. They'll start chowing down on their grain and then all of a sudden they back away. Sometimes they'll just lay down on the ground really quickly. They'll start flopping around. They'll stretch out. They'll all of a sudden start looking really colicky and really uncomfortable. And remember, horses can only show us they're painful in so many ways, rolling, pawing, doing these things. So people think they're colicking, but they were just eating. So why are we colicking now? Usually that is the presentation for a choke. Sometimes it will take time before the feed stuff start coming out of the nose. But as you can see down here in this picture, we have a lot of discharge from the nose of a patient that otherwise was healthy a few minutes before. And so what happens is the food starts backing up in the esophagus. They're swallowing saliva, it builds up and it starts coming out. Sometimes we'll see the grain coming out of the nose as well. My dog is talking to me. Cora, honey, here. Thank you. Sorry. Sometimes we'll see the grain coming out of the nose as well. And sometimes we don't. Sometimes all we see is saliva. I like to hammer home points. So my main point here is please, please, please do not stick a hose down your horse's mouth. When you put that hose up here in the mouth, this is a kind of a cross-section anatomical view. The farthest back you're going to get is about right here. And right here, if you turn that hose on full blast and you start trying to blast out that choke, you are subjecting the upper airway or the beginning of the windpipe to a lot of fluid that it's not supposed to have. And that really, really increases our risk of aspiration pneumonia, which can be a pretty darn bad complication. And so don't take an otherwise simple choke and turn it into an aspiration pneumonia by sticking the hose down there. I was taught it when I was a kid. I honestly, in fact, until I was like in veterinary school and they were like, do not do this. I always thought that was one of the things you were supposed to do. But please, if you take nothing else away from this, don't stick a hose down your horse's mouth. You are not going to get to the area where the problem is, and you're not going to do any benefit. What you should do is remove the food and start some hand walking if it's safe to do so. Sometimes that little bit of distraction is enough to allow the food to start breaking down on its own if they're not adding to the material by eating more. You can do some light massage of the neck and just some nice relaxation techniques. And sometimes relaxing your horse enough will allow that food bolus that's kind of gotten lodged in a place it shouldn't to move and travel down. Many esophageal obstructions will resolve without veterinary intervention. But if they don't, if they've been going on for 30 to 35 minutes, 45, an hour, and they're still not resolving, then we like to see them. And we like to see them within, that period of time because we don't want them to develop secondary aspiration pneumonia. The longer they're not able to swallow, the more food particulate that is congregating around their airway. And we don't want anything to make its way down to the lungs and cause a pneumonia. There are many predisposing factors. Sometimes it's just the horse that is young and super excited to eat and comes in and bolts their food really quickly, and they swallow it before they chew it. And many of our grains will kind of expand as they are mixed with saliva, and they expand in the esophagus before they make their way to the stomach completely, and we get an esophageal obstruction. Horses that have severe dental pathology or aren't able to chew their food efficiently will oftentimes have a choke episode if we're not slowing or soaking the feed before we give it to them. And while I love senior feed and beet pulp absolutely have their place, they are some of our biggest offenders of causing a choke for two reasons. Oftentimes horses that are on senior feed have dental pathology, so they're already predisposed. And if they're eating it very quickly, or if we don't soak it beforehand to kind of already do the pre-puff phase, they will eat it quickly and can choke on it as well. So we are going to move on now to ocular emergencies, eyes. So I love eyes. Eyes are one of my favorite things that I treat. And my main takeaway from this is that all eye concerns are urgent. They might not be something that your veterinarian has to see like that minute, but they're something that your veterinarian should see that day. And the reason for that is horses have these big, beautiful eyes, and I love them and we love them, but they're very wimpy. Their immune system and their ability to heal from even the really small things that other species would heal just fine from is not what the horse was blessed with. They are so prone to taking a small injury and turning it into a major infection, which can be compromising to the vision of the horse. The good thing about eyes is that for the most part, they are not life-threatening emergencies, but they are vision-threatening emergencies. And so again, phoning your veterinarian and letting them know something is going on is really important to do the same day that you notice the problem, and letting them determine whether they need to see it that hour, that day, or the next day. Let's talk a little bit about the anatomy of the eye. So this is a side view of the eye. The majority of the eye we don't see. It's set back into the skull or into the orbital socket, and it's made up of this back component here, which is our vitreal chamber where our retina lives. And that's what does the corresponding parts to our optic nerve to make us have vision. The lens of the horse, we're kind of working from the back to the front. The lens of the horse does the focusing, just like in us. We can see cataracts and things like that change. It's attached here through, we have our pupil and our little zonule fibers that make up our iris here. So we have the colored portion of the eye. And then we have our anterior chamber, which can have some inflammation. This very little kind of thin strip here is the cornea. And the cornea is where we see the majority of problems in the horse's eye. So over here, we have a cross-sectional view of the cornea. The cornea is made up of 3 different surfaces. We have the epithelial layer on the outside, which is about a third of it. The majority of the rest of the 2/3 is made up of the stroma. And then we have our endothelial layer at the bottom, which is just 1 cell layer thick. And we oftentimes, when we talk about a corneal ulcer, that is a breakage in the epithelium, which allows us to have exposed stroma. And we're going to look at some images here of eyes. So corneal ulceration can be simple, meaning that it's not infected and it's very superficial. That's this ulcer right here. We have this light stain uptake, which is called fluorescein stain, which does not stick to the epithelial layer. So if you put fluorescein stain in the normal eye, you will not see any uptake here. It will only stick to the stromal layer here. So that's a simple, non-complicated ulcer. Complicated ulcer is an ulcer that is infected with either bacteria or fungus, or that is deeper. And so in these images down here, you'll see this is the same patient that presented on the 26th. And we had a relatively small lesion, and even despite appropriate intervention, it blew up into this very, very large lesion that was infected in the matter of 3 days. So how we treat these are with an examination. Typically, we are going to be doing antibiotics. We do not want to be using steroids. So one of the main things that I see happen is people have all these ointments lying around and they see a little flare and they're like, oh, I'll just put this ointment in that my friend from down the aisle has. Well, if your friend down the aisle has an ointment that has a steroid in it and you put it in a superficial ulcer, you can make it a complicated ulcer because steroids will really decrease the ability of the eye to fight off infection. And we can see some major infections happen as a result of eyes that are inappropriately treated with steroids. Atropine is going to dilate our pupil. It kind of helps with the muscle spasm that's happening in the eye. We'll oftentimes use systemic anti-inflammatories like Banamine to reduce the pain, and then certainly putting a protection there so that they can't scratch their eye themselves. Here is a patient that had a fungal ulcer, this big plaque of fungus here. This is after we kind of scraped off all of the fungus. Here is it as it was healing, and here is it when it was finally done being treated. And even from here, the scar kind of healed down quite a bit from there. But I think eyes are fascinating, and I really love looking at all the things they do. Here we have a picture of an ulcer that is melting. You can kind of see this like rim that it's starting to get on the bottom here. That is starting to be a melting ulcer. And when that kind of popped open, we have this image. This is the same horse a few days later. This very dark crater right here in the center, that is a desmetocele. That's one cell layer thick. That's the last little portion of the cornea that's holding on before this eye ruptures. And this particular patient in these photos actually healed incredibly well and is fully visual in that eye today. This was an emergency that presented. This horse ruptured its eye. He had a penetrating foreign body into the eye itself, and this is actually a portion of the iris, or the colored part of his eye, that is now fallen out of the eye. Here are some vessels that are coming really well to the cornea. This patient up here with a very yellow eye has uveitis or a lot of inflammation in the eye. And this kind of hazy blue eye is actually a patient with glaucoma. So there's lots of different things. But again, the answer to this is that if it's something different than is normal for your horse, you should let your veterinarian know the moment it pops up rather than a few days later, because early intervention, as with most things, are crucial. We kind of already summed this up, but the equine eye is prone to infection and melting. We're going to aim our treatment from ulcerations at preventing infection. Inflammation of the eye can lead to blindness or chronic pain. We can use different systems to deliver medications. Serum is one of our favorite things, where we actually draw blood from the horse and put it back into their eye. Banamine is great at controlling inflammation in the eye. And kind of relating back to our colic talk, eye pain, chronic eye pain can have a predisposing factor to a cecal impaction. This is a great picture of an iris that has lost a lot of its stability, and you can see he has multiple pupils. We are almost done here, crew. I know. I hope we're not losing. It's hard when I can't see your faces, see if those eyes are glazing over. So this is my little warning about things that are going to start looking a little graphic for our wound talk. I do have pictures of some wounds here, but again, really quickly, things you need to know. Your horse comes in, you get to the barn, your horse has a wound. What should you do? Assess the bleeding. Is it coming out in spurts or like a chronic stream, or is it just kind of dribbling? If it's just dribbling, which most of them are, then they're not likely to bleed out. If it's coming out in spurts or it is pulsing, that typically means we have an arterial bleed, and we take those more seriously. We want to apply compression over the area that's bleeding. If the blood comes through your bandage material, don't remove the bandage, just apply more layers on top of it and call your veterinarian. Be mindful of the location of the laceration. The location really can play into how severe a laceration is. Even small lacerations on a leg or over a joint can be much more potentially complicated than a large laceration over the muscle. So where is the joint? Is a body cavity affected? Is it a deep penetrating wound to the thoracic or the lung cavity or the abdominal cavity? Where is the location? Those are important things to know. Take a photo for your veterinarian, one that's close up and one that is far away, because close up helps us assess the wound itself, but the ones that are farther away help us know where on the body it is. And I'm going to show you some examples. As far as cleaning goes, there is not a one-size-fits-all answer here. So I always recommend, again, contacting your veterinarian to get their interpretation of your particular wound. But For the most part, the solution to pollution is dilution, and cold hosing is oftentimes very, very helpful to allow us to decontaminate a wound before we start putting it back together. We want to avoid strong detergents or antiseptics because while those also kill the bacteria that might be there, they also sometimes kill the healthy skin cells, and we don't want to do that. Blue coat, it's kind of the nemesis of a lot of veterinarians because it sticks to the wound itself. So if you're going to have your veterinarian out to look at the wound, don't apply blue coat because it just makes it so much more complicated for us to actually see the structures that are involved. So here are some wounds. Which wound do you think is the most severe? Hey, and I know that you can't actually necessarily answer, but if you want to type in the chat screen, I might be able to find a way. So we have wound 1 here, which is large and on the hip. We have wound 2, which is on the face. Wound 3, which is here over our chest, and wound 4, which is here on our distal limb. And I'll keep cruising along because I know we're about at time. If anyone wants to answer, you can. If not, we'll keep cruising along. The answer to this is that wound, oh, we've got an answer. Wound number 3, 4, we've got some quotes in here. So the answer to this is actually wound number 4. Wound number 4 is over a joint. And while it doesn't look like much from this photo, especially when you compare it, excuse me, all the other things that are going on here, it is the most severe. And we're going to look closer at that as to why. Oh, here we go. So this is an example of this exact same wound, okay? That's this wound here, of what it looks like close up. Close up, it's not so bad. I'm like, oh yeah, I can put a couple stitches in that, we'll be fine. But when we zoom out and we see the location right over the fetlock joint, then we start to get more concerned. So if you're going to send a photo to your vet, take one close up. This is a helpful shot, but also take ones from farther away so we can exactly see where it is, because that greatly determines. When I saw this picture, I was like, oh, that's not so bad. When I saw these, I was like, we're going to need to come see that right away. This particular patient did have that wound. This is an x-ray from that horse where our sterile probe is going straight into that fetlock joint. This horse did fine with early intervention. He did have to go have surgery to have the wound flushed out and the joint flushed out. Joint infections are not something to be messed with. And the earlier we intervene, the better prognosis we have for soundness of the horse. This horse is doing great and is back to full work. This is the other wound that we looked at. This was a pretty massive wound that this horse had over her rump here. We were able to close that up really nicely. Here's our post pictures here, and then we have some really nice video or some pictures watching it heal up. This is really healthy granulation tissue. Everyone is always a little bit afraid of proud flesh. I hear proud, oh my, I don't want to have proud flesh. I don't want proud flesh. Proud flesh is something that we have to be mindful of and cognizant of, but it's not something to be feared. It is healthy granulation tissue that's just gotten a little bit too excited. And so while we do need to keep it at bay, don't be afraid of proud flesh. Proud flesh lets me know we have healthy bed, a healthy wound bed. We just need to tame it back a little bit. And there's no proud flesh in these photos. Mostly proud flesh happens on the limbs, but you can see this wound healed up really quite nicely. And this is just a face wound because I feel like people always really like images of wounds. This horse had a post that kind of came down on his head, and he had ripped off quite a few structures. This is actually the bone or his skull here that was affected, but it came together nicely. And to this day, you would barely know he has a scar. Last couple videos here really fast. Let's see, this is an arterial bleed. I don't know if you can see right here in the center of our screen, how that blood is just kind of flowing out. It's not dripping out, it is flowing out. We'll play that again here for effect. So those are the type of wounds that we definitely want to apply compression to, and to not remove the bandage material if it bleeds through. The reason we don't remove the bandage material is you disrupt the clot that the body's trying to form. The body's trying to stop the bleeding, and if we let it, it will be able to, for the most part, as long as it's not a major artery. And in this area, you can see that while it is an artery and it is bleeding, we can certainly get that to stop. And this particular patient also did just fine. Get to our next screen. All right, fever. We have like 2 really quick things coming up, and we're going to fly through them because I know we're about at an hour here. So fever is another common presentation of pain in the of emergencies in the horse. So oftentimes what we will see with horses that have a fever is they may have a limited interest in food. Sometimes they don't want their grain, but they'll kind of slowly pick at their hay. Oftentimes those horses have a fever. Sometimes they're quiet or dull. They may lay down, but they're not like throwing themselves up and down on the ground. They oftentimes will have a really increased respiratory rate because they're trying to breathe off the extra heat inside of them. So their respiratory rate will increase. A normal temperature in a horse is between 98 degrees and 101.5. And you really need to take into consideration the ambient temperature, because if it's 100 degrees outside with 90% humidity and your horse just came in from the field where he was running around and his temperature is 101.5, but he's acting okay, he probably doesn't have a fever, versus the same horse that's been standing in a stall all day and we pull him out because he's just not eating, and you take a temperature and it's 101.4, but it's only 30 degrees outside, that might actually be a fever. And so kind of taking those considerations into effect is important. I'm going to fly through this here. I'm just going to show this is, and I can link to these later, but clients often ask me how to take the temperature of the horse. And so you want to stand to the side. Do not want to stand directly behind them. That is not the place to stand. You want to stand to the side, introduce the thermometer. I like to scratch at the tail. And again, like I said, I can link these videos for you guys if you want to see. My poor horse has to put up with a lot from me. Okay, let's go to the next slide here. So differentials for things that cause a fever, we can have infectious agents, things like bacterial or viral diseases. We can see immune-mediated diseases, things like post-vaccination causing a fever. And then in very rare cases or very severe cases, we'll see sepsis, or in severe colics where we have that bacteria from the digestive tract that's gotten into the bloodstream, that will sometimes cause fever as well. So our plan is to try and identify the causative agent. We want to add in some anti-inflammatories. We want to hydrate them and provide really good supportive therapy so that they feel good. I love adding mashes or tea, which is where I will do like a scoop of the horse's normal grain into a true, like, large water bucket, and they will sometimes slurp that down. And then if we can identify the causative agent, we want to use targeted antibiotics to treat. Last one here, severe lameness. So differentials for severe lameness can be things like abscess, cellulitis, fracture, a severe soft tissue injury, a nail in the foot. And I really wish I would have added laminitis here, because that certainly is something that we want to talk about and something that should be addressed sooner than later. Abscess is probably the #1 reason that we get called for patients for a severe lameness that pops up sometimes seemingly out of nowhere. And in this particular image here, you can see we've got this gas opacity, this darker opacity in the foot, right here, right here, right here. All of that is abscess in this particular horse. Let's see if I can get this video to play down here. Right here is an abscess that's draining. It's like flowing out. That was quite a satisfying one to open. We unfortunately can see horses that will have a fracture, which is what we see in our x-ray up here, which that certainly those horses are presenting non-weight bearing on the limb that is affected. Cellulitis is an infection under the skin and certainly can also present with a fever, and usually does, as well as a swollen limb where they're very lame on. We're going to skip to our last one here, which is a nail in the foot. Should you pull it out? Again, major takeaway, please don't pull it out. This particular patient had a nail going straight in here. The reason we don't want you to pull it out is because we want this x-ray. We want to know that no vital structures have been touched. So leave it in, call your veterinarian and get an x-ray, because when I look at this on the left, I don't know if that's touched a synovial structure or a joint or a bone or something that's going to be potentially really, really bad, or if it hasn't. And with this x-ray right here, I can see, beautiful. We've not touched anything important. We can pull this out. We can pack the foot. We can treat like a generalized abscess, versus if this nail had gone a few centimeters further and touched the back of this navicular bone, that would be a very different prognosis. And there's no way really to retrace the tract of the nail other than with the nail in there. So please leave the nail in. We want this x-ray. All right, I'm sorry we kind of zoomed through those last ones, but I realized I really talked about colic for a long time. Do we have any questions? And I don't know if I can unmute it, so maybe Molly, I will leave that to you.
Yeah, there's one that says, "Thank you very much for an interesting talk. Much appreciated," from Penelope Sachs. So
It's a lot more fun when we get to do it in person. So
yeah, right. I will say thank you so much for doing this. It was very enjoyable. Anybody who missed it's going to be able to see it on the website because it is recorded. So thank you very much for your time, and
absolutely.
it was very interesting.
Well,
Actually,
thank you very much. If you guys have any other questions, or you think of questions, or people who watch it later have questions, you guys, I'm sure you have my contact information,
I do.
Molly. So if you need
I
it,
do.
you
I
can pass
do.
that along.
Thank you very much on behalf of all of IDCTA, and this is something that's going to go down in, in our history as one of our educational things. So thank you
Oh,
again. I
well, it
appreciate
was
it.
lovely virtually meeting all of you.
Very good. All right.
Have a great evening.
Good night.